I'm going to talk about three things today, and I'm going to try to link them together. And hopefully, this is going to make sense. I'm not completely sure it makes sense, but that's why I'm looking forward to this talk, because I'm hoping we're among friends, and you'll tell me when I'm completely nuts. The three things are data, um, constructs in mental illness, and by constructs, I really mean something like sickle cell anemia, where there's a clear underlying biological cause. And as I don't think I have to argue too much, the relationship between the data we measure and the constructs are fuzzy. That's probably being generous. The third part of this triangle is cultural context, and I'll say a little bit more about that at the end. I have a hope that maybe measuring data in multiple cultural contexts will give us some real insight into the true underlying constructs relevant to mental illness. And then with more data, we can manage a virtuous cycle. But I haven't proven that yet. But I'll tell you what we're trying to do. First slide, yeah. So I come from the National Institute of Mental Health, which is the largest funder of mental health research in the world. And we do envision a world in which mental illnesses are prevented or cured. Our mission is to transform the understanding and treatment of mental illnesses through basic and clinical research, paving the way for prevention, recovery, and cure. So we fulfill this mission, by funding mom and pop investigators, right? Measuring large amounts of data has become pretty easy for mom and pop investigators. Genomics, MRI, data from personal tracking devices, which is the data that's actually causing me the greatest concern at the moment. And so lots of people, when they're talking about big data, so here you're meant to believe that the streams of water represent streams of data that these mom and pop investigators are measuring, right? So lots of people, they get worried about the size of the data, and they think that this is what's going to happen to us. I've been hearing these concerns for the best part of actually my whole career. I have been working in data one way or another, and storing large amounts of data is an ongoing concern. But it turns out I think, a needless concern, because the experts in managing data find good ways to build infrastructure to deal with the data that exists at the time. 10 years ago, people told me, you'll never be able to afford to store a petabyte of data. Well, that was true 10 years ago, with storage costs being what they were. Today, the NIMH Data Archive, which I'm going to talk about in a minute, holds 7 petabytes of data. And I don't spend any more to store the data today than I did 10 years ago to store a 10th or a 20th of the amount of data. Things scale. You do worry about personal tracking device data, or things that might generate data more quickly than the Moore's law exponent that drives data storage costs down. But it hasn't been a problem in my career. So the real problem we face in data in mental illness is not volume. The real problem is the heterogeneity of the data, and I'll show you just how bad it is. But I have a feeling that everyone in the room probably understands how bad the heterogeneity truly is. A second component of this is our lack of a good theoretical framework for mental illness. I come from the field of protein crystallography, where there's a great equation. And if you've got the molecular structure, you can calculate what the intensities are from the crystal, and then you can measure the intensities and see how close your structure was, to what you expect. We don't have that sort of framework in our field. So we don't have the theory. I don't think we have the tools to measure what might actually be relevant in the brain, which might be something at the molecular level, managing data over large, measuring data over large components of the brain. All right, so what do we do until we have the framework and the tools? All right, and I have to say that this is not a simple translation, right? This is not a zucchini versus courgette type of problem. The question is really, what's the right way to measure data that's relevant to mental illness? So I've shown you greengrocers and I've shown you pictures of some things you can eat. So your constructs now that you're thinking about are related to food, right? What if the right construct for mental illness is actually something more along the lines of how much oil can you get out of a seed, or a nut, right? Might be true. I'm stretching an analogy, of course, but I mean, we don't really kind of know what we should be measuring, right? And I think if there's good news, I think this is not an issue. This is not a mental health issue. I think you see these sorts of things in cancer. 40 years ago, you talked about tumors in terms of the location of the tumor. You don't do that anymore. You talk about the mutation because we figured out that that was the right language to talk about cancers. So like cancer, we really need to engage in a true names project. And Zach Kahane at Harvard Medical School has talked about these idea of true names for disease, although he's not published on it, and I don't quite understand that. And but I really want to give him credit for this concept of a true name or a true construct for underlying disease. All right, so I've kind of sketched a fairly bleak picture so far. We don't know what data we should measure, and we don't know the relevance to mental illness. So what can you do? Well, you collect the data. You organize the data in some way. It's important that you use a data architecture that's flexible, because you don't know what sort of additional data you're going to need to add on top of it. You don't know how you may need to rearrange the data at a later time. So that organizational framework is important. And you think about Sherlock Holmes consulting the train tables, and realizing something from that additional piece of data. Maybe that's where we could get to in our illnesses, and I do think that understanding, as I said, brain circuits relevant to particular behaviors are likely to be important. How much information do we need? I don't know, but I do know that it took years of experiments in the human genomics field before we realized that you needed thousands to tens of thousands of research participants worth of data to get a signal. In human magnetic resonance imaging, it's becoming clear as well that these studies that involve an N of 100 folks are not reproducible in general. So I think thousands are going to be needed there. I have to give real credit to the UK Biobank for making data available from large numbers of subjects and showing that you can get meaningful signals in many ways from those folks. But for clinical phenotypic mental health measures, we don't have a clear answer, but I'm betting on thousands to tens of thousands. And if you believe that, then we actually need ways to link data from multiple labs together, right? All right, so what's the problem in doing that? Well, the problem is that we're very good at inventing new measures, right? So the data archive that I am in charge of has been accepting data from research labs since 2008. In 14 years, researchers have defined 4,200 different data collection instruments, and the pace of data dictionary requests has not slowed down over time. So that means that we have 400,000 quasi-independent questions in the NIMH data archive. We have data from 500,000 research participants, but when you have 500,000 columns, 500,000 rows, and you have 400,000 columns, you have a very sparse matrix, you know. So how do you, how many constructs, concepts, circuits do we really think we need to understand mental illness? Is it really close to 4,200? So I doubt it. If you get bored in the talk, or if you are watching this online later, you can go to the data dictionary tool at the NIMH data archive, and I chose a term completely at random. I clicked on anxiety. We can search on all sorts of things, right? So, and I should back up. There's that. You see the 4183, that's the number of data dictionaries that we had on the day when I made the slide. You know, I'm sure there's more today. So you click on anxiety and you get 62 independent data dictionaries. And over on the far right, you see the number of research subjects that we have data from with that particular data dictionary, right? So there's 62 of them, and the world would be a much better place rather than having ends of several hundred for each data dictionary if we had an N of 300,000 for a single anxiety-related data dictionary. You can do that. You can look at this in other ways. If you try to look at the number of independent questions in the data archive, it's that small number, the 2848. It's a big number. If you start to look at those questions and you start to look at the terms that are used that are relevant to anxiety in the data in the NDA, you see a lot of words that the concept is fuzzy, right? The underlying construct is unclear. Is the construct for separation anxiety really different from the construct for agitation? If so, how? I'm doubtful that there are 2,800 different underlying constructs. I'm doubtful. I don't know, and I hope it's not true, but I guess it could be. So with these 2,800 different anxiety-related questions, it's a big number, and anxiety is not unusual. You can look at any of the sort of anything that you'd like in NDA. You get similar sorts of numbers of questions, numbers of data dictionaries, tremendous heterogeneity in the way we measure data. So there's kind of a Tower of Babel sort of problem going on here. What are we trying to do about it? Well, at the last big in-person meeting of the International Alliance for Mental Health Research Funders here in London, I gave a talk along these lines, and there was a lot of consternation in the room amongst the funders, and there was a real desire to do something about this issue. So the funders started to work together, and a number of us agreed that we were going to require those researchers who got awards to collect a single set of common measures. Here are the participating funders. We co-chair this effort with the Wellcome Trust, and it's been a great partnership from my perspective. And the IAMHRF is sort of the secretariat for this issue. In addition to the funders, we have a couple of journals that are involved in this effort. We're hoping at some point that we can perhaps get the journals to do the same thing that happened in crystallography, which was, if you want to publish a paper in this journal, you have to use you have to deposit the data in a certain archive, and you have to use a certain format to do that, right? So these journals and funders form something we call the Common Measures Board. And the immediate objective of this initiative is really to evaluate the strengths and limitations of this first round of common measures that we've selected. A second important question is whether these common measures really do allow us to aggregate data measured in different labs together more easily than you can do today. And in the longer term, Miranda Wolpert at Wellcome talks about this in, I think, a very useful way. We really do aim to identify and adopt robust measures that can be applied in many mental health research settings and can really help identify these underlying constructs, equivalent to the hemoglobin A1C test for diabetes or the 5-year survival measure in oncology. Here are the measures that we chose, mostly not controversial. Age, sex at birth, the HUDAS 2.0, the DSM cross-cutting, PHQ-9, and the GAD-7. These are the measures for adults, clearly with a strong anxiety, depression focus, which was arrived at, sort of with consensus of the funders. You see, we don't have anything related to psychosis. That's a real loss, perhaps. So, we're thinking about that. For kids, there's no freely available measure that's equivalent to impairment. So we don't have that. We would like to, but we don't have. There are measures, but they're not freely available. We do have the DSM cross-cutting for kids and the RCADS 25, which is kind of a mashup of the PHQ-9 and the GAD-7, although I'm sure Bruce Chorpata, one of the co-inventors of that instrument, wouldn't necessarily frame it that way, but I think that's probably a fair assessment. So you can go to the homepage of the NIMH Data Archive, you can go to the Common Data Element page, and you can get the exact questions for each of these instruments, which can be a little hard to track down otherwise. Importantly, in these data dictionaries, for what I'm going to talk about in a little bit, you can also get the list of languages that these instruments have been translated into already, that the copyright holders have approved of. So early on, the Common Measures Board realized that we had ambitions, but that we didn't necessarily amongst ourselves have all of the knowledge that we needed. So we advertised the availability, or we advertised that we were creating this Common Measures Advisory Board, and we used our own advertising networks to make it known that we were looking for folks. And I guess I'm not a joiner, but I read our advertisement. I thought, who in their right mind is going to send us an application for this? Well, we got 150 applications in the first round, and these were from people who were extraordinarily well qualified. So we chose a group of 14, I believe, from this initial list of applicants. And they became the members of the Common Measures Advisory Board. Everyone else, we kept their emails and we put them into a community of practice, which we've used we've met once over the past 18 months with a community of practice to tell them what we were doing and to see whether what we were hearing from the Common Measures Advisory Group was believable to the members of the community of practice. So the CMAs met monthly for nearly 2 years. And during that time, we have gone through every question in every one of the common measures. And a key theme during the discussions of each of these questions were issues related to cultural context. And this was a real surprise to me. So, the common measures were generally developed in middle or high income countries. And consider just one of them. This is just a single question from the PHQ-9, but like I said, there's been months and months of these, and we could talk about any single question from any one of these data dictionaries, and we would come up with the same problem. Consider this, over the last 2 weeks, how often have you been bothered by poor appetite or overeating, right? Well, now, this is perhaps an especially bad one because, you would hope that you're not asking 2 questions simultaneously, but the author of this question clearly thought that eating disorders could be covered by either end of the extreme and that was the underlying construct that they were measuring, right? Well, what happens with this question in a low-income setting? What happens with this question in a setting where the environment is unsafe to leave your home or to go too far, right? Those are really, I think, likely to be very different constructs that you might have people endorse, yes, I have been bothered by this, but not because of my appetite, it's because of something else entirely. And yet, we actually know each one of the questions in the PHQ-9 has these sorts of issues. But the PHQ-9 as a data collection instrument is a very useful instrument in a wide range of cultures. There's translations that happen, and I think it will be very interesting, I think, to look at those translations in detail and see what we could learn from that. But there is some signal to the 9 questions together that I don't think I could be convinced that this single question would give me that same type of signal. So I think that thinking through issues related to cultural context is likely to be the focus of the CMA as we resume our conversations in the next month or two. When cultural context first came to the fore in these discussions, I really despaired for quite a while because I thought, well, so in addition to having this heterogeneous data and these poorly defined constructs, I now have different cultural contexts that I have to worry about. And that's never going to work, right? But I've convinced myself that there's actually perhaps a virtuous circle here, that by measuring these common measures in different cultural contexts, perhaps we can really start to understand the underlying constructs. Perhaps, like is true for the PHQ-9, the noise will be averaged out over enough cultural integration. That I think is a speculation. It really is but I'm hopeful that today we can have a little conversation following this talk about whether that idea has any merit in your, in the way you think about these things. So I really do think that the conversations about this effort to deal with data heterogeneity in a field where the underlying constructs, and I have purposely not talked about the relationship between biology and the constructs. I really didn't come here today to talk about G-coupled receptors, but we could if someone wanted to, you know. I think that's a separate problem, a separate issue that we are dealing with, but hard. It's hard. It's a hard problem. So in summary, the volume and heterogeneity in data from research labs is, the volume's not a problem, the heterogeneity is a problem. I have convinced myself, and I suspect I know there are people in the room who are far more knowledgeable about this than I am, but I think that equivalent heterogeneity exists in data coming from electronic medical records or other things that you would intrinsically think, oh, they've got their act together. It's just on the research side of things that we keep inventing new instruments. We have a resulting lack of common language and understanding because of this data heterogeneity, no matter where it's coming from. The IAMHRF has made a first stab at trying to get people to measure the same data in different contexts with the aim of linking data from different labs, but hopefully also telling us something about these underlying constructs. And I think that dealing with the issues related to cultural context perhaps really does open an opportunity. At least I've convinced myself that there's fertile ground for work there, but perhaps you're going to tell me otherwise. There's something I haven't talked about, but has ended up being true in magnetic resonance imaging data, and I think is likely to be true for us as well, that there's great heterogeneity in the data analysis tools as well. And someone in the MRI field told me fairly recently that it's only recently have we had cohorts large enough that we could figure out just how bad our data analysis tools were. Before we had noisy data and data analysis tools that weren't all that good, but we didn't know about the tool problem until we had a harmonized data set. I suspect we may end up with similar sorts of issues here as well. So this last slide is kind of meant to indicate that it's time for us to get to work. I've outlined a path that I think might be fruitful, but I'm really interested in getting your reactions to those ideas. So thanks for the attention to the talk and for the invitation to come and speak with you. I'd be happy to answer questions.
So much, very controversial and very interesting. Okay, there are three. I hear my questions. As long as I have a chance to ask my questions, I will let other people go in first. We'll have to share the microphones if that's okay. Yeah. Great. Yes, please.
When you're looking at the measures in the different contexts, are you leveraging the wider social determinants of health in the demographic and other care data?
The answer is sometimes. We have a fair amount of that sort of data. It's not as complete as you might think it should be. For a lot of reasons that we probably don't need to talk about, but yes, but I'm not sure that we have. I think we probably need harmonized instruments across some of these demographic measures as well. And we have not at the IAMHRF thought about that yet, but perhaps we should.
Katrina?
Hi, I really loved your talk, but I'm going to question something.
Please.
Which is the questionnaires like PHQ-9 and GAD7 have obviously come out of a construct. They've come out of the DSM definition. And so context is everything in mental health. And I think we saw these constructs break down at the beginning of the COVID-19, where we saw that people's scores on GAD7 were astronomical, but it didn't quite look like a disorder because it was just that they were scoring high on an instrument that wasn't made for that context. So if you then go from multiple contexts to showing this signal, therefore the construct, you're in danger of.
There's no, that's right. And I wish I could disagree, but I can't. And there is a real danger here of you might think about COVID as happening in a different cultural setting than the pre-COVID world. But I'm not sure that there's a lot of noise, right? And so the question really becomes, what can you average across to get signal out of the noise? And I'm not sure. I know that I don't know the answer. I'm hopeful that the funders together can try to figure out a way to try to get to that answer. The funders and the research. I mean, all of you, right? I think these are the key issues. How do you integrate over? What do you integrate over to get signal out of the noise? And
what is that telling you when you do?
That's right. That's exactly right. Yep.
There are 3 more questions, but I will be controversial and I will ask my questions before the others. Sorry. It's a nice follow-on from Katrina's question. So you kind of really set up your presentation saying that heterogeneity in mental health measurement is a problem. Can I ask whether actually there is something positive to harness from heterogeneity, and the problem is not that we are using different instruments, but that some people use bad ways of assessing, so that the problem is not heterogeneity, is badly measured concepts, and that forcing people to using the same measure, I'm wondering whether we're going to miss something by trying to diminish heterogeneity, which could be in some ways positive.
No, and I think there's an important something that I didn't go into is that the funders are not saying you may not use other instruments. It's just that you must use these. And if you think you have a better way of measuring anxiety in a COVID world, do it. Because what we really want is the comparison between the GAD7 and an additional instrument. So this is not a prohibition against exploration. It's a data linkage effort, not a you're going to do it my way and no other way. Yeah. That's a really important point. Yes.
Okay, great. Thank you. Yes. Oh, sorry. Oh, yes. Sorry.
Yeah, just a fantastic talk. Thank you very much. And speaking from the electronic health record sector, not only is it exactly the same sort of situation, but the framework I think is really helpful here as well. I'm curious about, maybe this is putting the cart before the horse, but if the Common Measures Board is successful in identifying ways to improve this core set of measures, how do you version that with the common use of those items in studies that have already been run? Yeah,
I worried about this a lot starting out. And I know that Miranda Wolpert at the Wellcome Trust has also worried about this a great deal. But there's a time element here, right? Because we instituted these common measures about 18 months ago. So I have data rolling in from several hundred independent researchers into the NIMH data archive with these measures. Those data sets aren't going to be released until the grant is over, when typically they're 5 years long. So we're not looking at version 2.0 for another couple of years. I'm hopeful that, especially with comparisons to other data collection instruments, that we may really get to a better set of measures in a couple of years. And then I think the world would be a much better place if we had a nonprofit that was aggregating the version 2.0 questions and making them freely available to the research community, and then funding the development or managing, if others are funding it, managing the continued improvement of the measures. I think that sort of framework is going to be necessary, but I don't think we need to worry about it right now.
Great, thank you. Yes, I'm sorry.
This is for the recording.
I suppose I like where you're going with this idea of standardizing measures. I am concerned somewhat that there's a drive to sort of standardize measures, and I feel that sometimes, to build on the previous point, you can end up with these measures that are sort of so bland and so kind of an attempt to be ubiquitous, they end up catching nothing.
Yeah.
I would propose perhaps a slightly different approach. I just want to hear your thoughts on it, that rather than standardizing the measures, ensure the measures are compatible, so that you can, instead of having, a standardized measure that will give you a GAD-6 score, have a measure that is equivalent to a GAD-6 score, that allows you to build in that cultural difference or that societal difference. If you do that, what you probably could do is take a lot of your existing data sets, rather than sort of scrap them, you can begin to say, this is equivalent to a standardized measure, rather than necessarily a standardized measure itself.
I don't really object to that, but I will say that I employ a lot of data curators on the team for the NIMH data archive, and I have worried about these harmonization efforts. I talk to people like Zach Kahani and others, and I talk about the scale of the problem that we have, and I suspect I could employ everyone who's interested in ontologies in the world, and and not come up with comprehensive measures. So I don't object to what you're thinking about, but I think you can't discount the effort that it really takes to do the harmonization, and that could be a tough problem. Yeah.
So I wanted to ask you about a region of the world where there's vast underrepresentation. So in Africa, particularly psychiatric genetics and in my own field of depression, there are very few studies. Many of the instruments haven't been translated in local countries, and some of the tools that have been translated and best validated were developed with NIH money or with WHO money, and are now being charged to the investigators in the African countries to then administer to people in research studies. I just wondered how whether you thought that was a substantial barrier, and how NIH and yourself think about that problem going forward and how it might be addressed.
Yes, and I can't pretend to stand here as a federal official and there's what I think about this personally, and then there's what the federal government not only allows but expects in many ways. We give researchers money to do research. They are under no obligation to provide the fruits of their research for free, and in fact, that you can really also argue that if you're not charging money, someone has to maintain the instrument anyway. So but it doesn't feel at all right or good, to me. That's why I like this idea of kind of a nonprofit that would take this forward, so we didn't have problems like that. And I pointed out with the kids' version of measures of impairment, There are such measures. It's just that you have to pay to use them. And the funders decided that with this first round of common measures, we needed to avoid those sorts of measures, which is part of the reason why we've ended up with the ones that we have ended up. I think the underrepresentation is a real issue, and I think the charging on top of the underrepresentation is a good point that I'm glad you raised, because it is a real problem. Yeah, yeah.
Thank you. Great talk. I was just wondering to what extent maybe PPI work, so like participant advisory boards or patient advisory boards, kind of have in maybe your common measures advisory board, because obviously some qualitative work has previously shown that in some of the key most used measures, actually some very key domains of the symptom experience of depression, for example, aren't actually assessed, like mental pain, for example, or social isolation. So I was just wondering kind of how you would go about ensuring those are covered or considered when you're kind of picking a measure.
That's right. And that is something that we've been talking about a good deal. So I should say first that we don't want to create new measures, right? So that's at least not now. I think there will come a point when that will be necessary. We're not quite there. We do have some measures some members of the Common Measures Advisory Group who endorse the idea that they have lived experience. I think that means different things to different people in that group. We have not set aside a certain number of seats for, as is done here in many funding, panels. We haven't done that. I think we might get there, but this is an area that we're still trying to navigate. What we really wanted from this initial group were experts in psychometrics, right? That was really what, and it turned out that we have found some experts in psychometrics that also had lived experience, so that was good. But I don't think it's enough, and I would appreciate any ideas you have about, you can catch me later. I'll be here all day about ways that we might strengthen that part of the effort, because I think it's important.
Do you have any more questions?
We have time.
Yes.
Hi, thank you for your talk. I was trying to form my question in my head, and I might as well ask whatever is coming up. It's quite interesting to see just how much you've highlighted that cultural context is quite big, which I guess we all kind of know, but just seeing that actually is a key issue or thing. So I'm going to try and ask a question that's all modeled up, but if it is this big, what are there some initial thoughts of how we could potentially start to measure it? But also it made me think about, I think in your slide you wrote, in high income countries, you're asking this way. But then I also thought about even in because of increased globalization and diversity, actually cultural context is quite important. So I think about myself, for example, I've grown up in Nigeria, lived in England, and now I'm in Wales. It's there's so much in there. So how do we even start to measure that in higher income countries? Because experiences are so different, globalization and diversity. And if it's actually quite big, then perhaps it's more, it's not as straightforward as just, high income country or whatever, there's so many interactions and experiences we have today that really confounds that issue. But I wondered what the initial thoughts on incorporating that and measuring that, because I am aware that that's not especially because we're so different, that's not a simple thing to measure.
It is not it's not a simple thing. I think different funders have different approaches to funding global mental health, and I'll put that name on top of this topic, although I'm not sure that's a perfect fit either. At NIMH, we have funded a pretty significant effort in infrastructure building in certain parts of the world. And those parts were not predetermined by us. We had open funding calls and we got good applications from people who were at institutions in certain parts of the world, and that's what we ended up funding. I think the Wellcome Trust has taken a somewhat different approach, but perhaps complementary in many ways, and I'm not really an expert, and I'll let others, I'll let others speak to that. But I think if my guess is right, that there's really a triangle here between construct, data, and cultural context, I think we're likely to need funding opportunities that call out that triangle very explicitly. And so we're not at a point yet where we're releasing new funding calls, but I really would like to hear what you all think, either now or later, about that idea of an RFA, that a request for applications that asked people to measure a particular construct in a particular culture or set of cultures with a proposed set of data, and how we might integrate over that, or see whether we could do that in a pilot study type of thing. Yeah.
Oh, we have 2 more questions if we still have time. Oh, perfect.
Thanks so much, and thanks so much for your talk. It was quite inspirational. I have just some random thoughts, so maybe you also find them weird and don't like them. But you talk a lot about constructs, and you do talk a lot about the data that kind of always been there, and it's about changing that and kind of adjusting what we have. But you also said some very good things about how the world is changing and how rapidly it's changing, how the data infrastructure is changing, how the tools are changing. And we see a little bit of kind of emergency of things like, we start listening to people a bit more, we start collecting more information, maybe text. We have tools that allow us to synthesize that text and see what's coming out there. In light of this, kind of, what do you think will actually happen in a few years' time, 5 years' time that you're talking about? Do we have to keep it this way, or can we open up to more data, different forms of data? And I know it's caused a lot of pain, but I think, Lucy said, this is a great thing. It's a great opportunity, that heterogeneity. Should we be harnessing that instead of massaging these things that we know?
So, we went into this, it's a great question. So we went into this, I think at least some of us on the Common Measures board went into this thinking, what we want is an item bank, and we want a researcher to come to the item bank and say, I want to measure anxiety in men between 21 to 28 years of age who live in Ethiopia. We'll make it very specific. Give me 2 questions that's going to get to that construct in that culture. The Common Measures, and we pushed this pretty hard with the Common Measures Advisory Group, and they were really opposed to this. I mean, they were really opposed to this, and there's no one on the group who has any stake in any of these common measures. I think their opposition came from, partially at least, from their understanding that within these instruments, the existing instruments, there is already some noise that gets filtered out by the questions, by the aggregation of the questions. And they were very doubtful that an item bank was going to give us that type of filtering. And they're good, knowledgeable people, and they may very well be right. So I still like that. I still like the item bank framing of the question, but I don't know whether the item bank would have to spit out 9 questions for, like the PHQ-9, and if so, you can see how complicated this gets, especially given the number of different cultural contexts that you would like to be able to think about things. And I'm thinking back again to the COVID question, that, you know, that you'd have to blow a whistle somehow. Now you don't have things that like COVID too frequently, but you really would have to blow a whistle and say, okay, until that date, here was what the item bank looked like, and now we need to think about this differently and think about how to map from where we were to where we are. Yeah, it's hard. It's hard.
One last question. Oh.
We have 3 minutes left, so we can take maybe 2.
Yeah, sorry. Rudolph, I'll get back to you.
Hey, I was wondering if you had any commentary on the idea of networks of symptoms being individual constructs rather than looking at like aggregate sum scores across scales to measure the construct of depression or anxiety.
Yeah, it's a good question, and I'm really not sure. We have not at NIMH had explicit funding calls to address that issue. It's not a bad thing to think about addressing at all. I think it's an important question. Yeah.
Thank you. It was a terrific talk. Very quick thing. One of your measures, for example, is copyright to the APA. Now you're starting to mandate that. Have you managed to persuade organizations like that to make it openly available and say so? And was that a challenge?
The answer is yes. That is, it is a challenge. We did with the measures that we have. They are all freely available, openly. You can go to the website and download them, and you just need to click on a button, and you have permission to use them. With the DSM cross-cutting, in theory, that could change tomorrow. We've certainly told them what we're doing, and they're supportive, and I don't expect it to change, but we don't have control over that. With the ARCADS 25, NIMH has actually funded an effort to keep that instrument fresh, to keep new translations coming, and we've worked with the copyright holders to do that. I think we will absolutely, as we move from where we are down whatever path we end up going down, we're going to need to make sure that the copyright holders are on board, and we're likely to have to provide financial support. But given the scope of the problems, the amount of money that we need to provide the funders with that sort of support is peanuts compared to the rest of the cost of this. Yeah.
Great. I'm sure that there will be lots of interesting discussions over coffee and over lunch today. So please join me in thanking Greg for a fantastic session.